Welcome back. We're diving right back into our explainer series, Decoding Complex Medical Coding Guidelines. Today we're tackling part 6, and we're looking at some of the absolute trickiest respiratory scenarios out there. You know, the human respiratory system is incredibly complex, and when things go wrong, well, coding for those conditions can definitely sink an audit if you aren't super careful. Let's get into it. So here's our agenda for this explainer. We've got 6 distinct case files to audit together today. Emphysema with chronic bronchitis, COPD and acute specific bronchitis, respiratory failure and obstructive bronchitis, COPD with pneumonia and bronchiectasis, emphysema versus unspecified COPD, and finally, cystic fibrosis with bronchiectasis. All right, let's jumpstart into case file 1, emphysema with chronic bronchitis.
Picture this. You're looking at a patient chart, and it shows emphysema right alongside specified chronic bronchitis. Right away, your coder instincts should be screaming for a combination code. The guidelines are super clear on this. We shouldn't use multiple codes if the classification already gives us a single combination code that perfectly identifies all the documented elements.
This is exactly why ICD-10-CM groups specified chronic bronchitis with emphysema under one single COPD combination code. That code is J44.89. It's a real-time saver, avoiding redundant dual coding. By dropping J44.89, which, just as a reminder, stands for other specified COPD, we fully capture the entire diagnostic picture. No need to break things out into separate codes at all. Moving right along, let's open case file 2, COPD and acute specific bronchitis. Okay, so in this scenario, we've got a 67-year-old patient admitted from the ED. They're presenting with an acute exacerbation of COPD, but wait, the documentation specifically names acute streptococcal bronchitis 2. That means we have an underlying chronic issue flaring up, which is then complicated by a highly specific bacterial organism. Here is the crucial takeaway. ICD-10-CM actually requires a multi-code assignment here. Why? To capture both the severity of the COPD and the exact bug causing the bronchitis. We're going to need J44.1 for that acute exacerbation, then J44.0 to show the COPD is accompanied by an acute lower respiratory infection. And finally, we add J20.2 to explicitly tag the streptococcus. It's like a 3-piece puzzle, and you absolutely need all 3 pieces to see the full clinical picture. Things get a bit more intense in case file 3, respiratory failure and obstructive bronchitis. Look at how the pulmonologist worded this. What's super interesting here is the explicit link they make between the acute hypoxic respiratory failure and the underlying exacerbation of chronic obstructive bronchitis. We are dealing with 2 very severe acute conditions happening at the exact same time. So, how do we sequence this? Well, because the acute respiratory failure was the main reason the patient had to be admitted in the first place, we sequence J96.01 first. That's our principal diagnosis. Then we follow it up with J44.1 as the secondary diagnosis for the COPD exacerbation. Remember, the principal diagnosis always hinges on the problem chiefly responsible for the encounter. In this specific hospital course, that severe respiratory failure with hypoxia was definitely in the driver's seat.
Ready for a multi-system challenge? Here is case file 4, COPD, pneumonia, and bronchiectasis.
This one is a classic auditor's trap. We've got 3 major respiratory issues documented all at once: bilateral pneumonia, severe COPD, and chronic bronchiectasis. Honestly, this trips up a ton of people. Knowing exactly what we can and cannot code together within category J44 is absolutely critical here. You might be looking at this and wondering, wait, can I actually use 2 different category J44 codes at the same time, right alongside the codes for pneumonia and bronchiectasis? Like, can we really report J44.0 for the infection and J44.1 for the exacerbation, plus J18.9 for the pneumonia and J47.9 for the uncomplicated bronchiectasis? Is that actually allowed? The answer is a resounding yes. Look at this definitive directive from the Q2 2024 AHA Coding Clinic. It clearly states you absolutely can and frankly should report both J44 codes to fully capture what's going on with the patient. Since pneumonia counts as a lower respiratory infection, it triggers J44.0. Meanwhile, the exacerbation still gets its J44.1. It is completely 100% compliant. Let's keep that momentum going. Case file 5, emphysema versus unspecified COPD. Imagine a 58-year-old patient comes in and the provider documents both emphysema and unspecified COPD. You've got a really critical choice to make about classification hierarchy here.
I know it's incredibly tempting to just code exactly what you see written on the page, but let's take a closer look. Now, even though there's an excludes to note for COPD and emphysema, it is actually incorrect to add J44.9 here. The only time you'd add it is if the COPD is further specified, like with an infection or an exacerbation. But since it's just unspecified in our chart, J43.9 for unspecified emphysema has to stand completely alone. This is such a great reminder of the absolute golden rule of coding. Always code to the highest level of specificity. Let the specific condition inherently capture the broader disease category. Think about it. Emphysema is literally just a morphological form of COPD. So tacking on an unspecified COPD code doesn't actually give us any new clinical data at all. It just creates unnecessary redundancy. All right, down to our final scenario. Case file 6, cystic fibrosis with bronchiectasis.
For this heavy hitter, the provider clearly notes that bronchiectasis is a common manifestation of cystic fibrosis. But the real driving force for this specific hospital admission? It's the cystic fibrosis exacerbation itself. So we're juggling a systemic disease on one hand and a localized pulmonary manifestation on the other.
How does this shake out? Well, if we follow the manifestation sequencing rules, the underlying cystic fibrosis has to take that principal diagnosis slot. Then, it's followed by the bronchiectasis exacerbation in the secondary slot. The systemic condition almost always gets priority over the manifestation. So E84.0 goes first, then J47.1. And if anyone ever questions that sequence, you can point them straight to the first quarter 2021 AHA coding clinic. It strongly reinforces that the systemic disease causing the pulmonary manifestation absolutely commands that primary spot. Definitely a great precedent to keep in your back pocket for whenever you're reviewing these complex respiratory admissions. Okay, let's wrap up today's audit trail with some high-yield takeaways. Always remember to use combination codes where directed, like with J4489. Pay attention to multiple J44 codes to capture distinct severity components and always sequence based on the primary condition driving the admission. And hey, make sure to join me next time for part 7, where we are going to completely deconstruct acute respiratory failure. We'll be getting deep into principal diagnosis selection when acute respiratory distress syndrome enters the chat. Thank you so much for auditing these charts with me today. Before you close out your very next chart, I want you to ask yourself, is your code selection truly capturing the specific, complex weight of your patient's illness? Or are you maybe settling for an unspecified code just out of habit? Keep questioning, keep learning, and as always, decode healthcare with Harshal.